This conference will now be recorded.
Oh, and we're being recorded. So Matthew is a clinical psychologist and an assistant professor. He is working as a BHC in a university-affiliated pediatric primary care clinic in East Tennessee, and it's about a 90% Medicaid population. He has really focused on pediatric integrated care, both in his graduate work as well as his fellowship, and is a graduate of the Vanderbilt LEND program, which is the Leadership, Education, and Neurodevelopment Disabilities, which helps to train providers to care for children with neurodevelopmental disabilities. So he has very graciously offered to talk about the stat. This is something that came out of an initial discussion last year at the CFHA conference, and I know that I'm very excited to learn more about his training in it and how they're using it in their clinics, so that hopefully we can continue to do what we do here at the PedsSig, which is beg, borrow, and steal from everybody else to make our clinics better. So with that, I'll hand it over to you, Matthew. Thank you so much for being willing to do this.
Oops, sorry, my audio is muted. Can you hear me now?
We can hear you now.
We can hear you.
Okay, great. Okay. So thank you for that introduction. I want to talk about a brief protocol that we could consider for autism assessment within primary care. And like Ali was saying, we have a 90% Medicaid clinic that I work at, and we have a developmental psychologist who's integrated in from Cherokee Health Systems a couple half days a week, but she does these comprehensive autism evaluations, but it's about a 6-month wait list. And so what I wanted to talk about today was just throwing a protocol out there that we have tried to tinker around with just out of sheer necessity of trying to get kids some quicker evaluations. And so not advocating, obviously, that every BHC would just go in and start diagnosing autism, but many folks who are working in pediatrics do have more advanced training in this and in psychological assessment. And so if you have that training, I think it makes sense to try to figure out a way to be able to adapt that for the primary care setting. So I wanted to look at 3 different primary care friendly tools for autism screening and assessment, and then talk about the protocol. So I'll talk about the stat, but then also a few other assessments that are in screeners that we've added in to this protocol. Obviously, we want to be able to identify autism as early as possible so that we can get kids linked in to early intervention services. And one way that we do that at the clinic that you all might do too is using the MCHAT, the modified checklist for autism in toddlers. And they came out with a revised version several years ago that it takes about 5 minutes for caregivers to fill out. You just have a yes or no question, and then a BHC can go in if the score is elevated and concerning and do a follow-up interview. And that's what we do in pediatrics. This is an example of what the parent would be filling out. And so 2, 5, and 12 are the ones that would be kind of reverse scored in this in this scenario. And so this is our first line universal screener that we give to all kids at 18 in the 24-month well child check. And there's some research behind this that kids who in clinics where you use this, kids are able to be diagnosed on average 2 years earlier than the national median age for diagnosis. And so if they fail 0 to 2 of the items, you just kind of wait and go to the next well child check and monitor. If it's in this medium risk range of 3 to 7 failed, then they would be referred to the BHC for a follow-up interview. And if they fail more than 8, you're supposed to automatically refer them for a more comprehensive evaluation. The problem is where, at least in our setting, like where do you refer these kids where it's not months and months long wait list? And so that's why we're trying to change this up a little bit. This is an example of just the follow-up interview that a BHC would conduct. And so don't feel overwhelmed. It's basically one question out of the 20 And if you point at something across the room, does little Bobby look at it? And it's this decision tree that would allow you to determine whether there's a pass or fail or not. So no matter the level of experience and training of BHCs, it's probably feasible to be able to train folks in your setting, at least in doing these MChat follow-up interviews if you're not already. So Robbins in 2014 looked at 16,000 toddlers at these 18 and 24 month well child checks, and 7% of them scored high enough for the follow-up interview on the MChat. And out of that, 2 were referred for the full evaluation. And of those referred, 95% actually ended up being diagnosed with autism or another developmental disorder. So it's a pretty nice screener to use. Another component, I think, of this assessment protocol, obviously, is just our good old clinical interview using all of our skills that we know already. And one way I think that we've tried to figure out to do this is to send the patient home with a developmental history questionnaire that they could then bring back to a future visit that would cut down on the actual time that you're interviewing the patient during the encounter. And so I'll give you, this is an example of what we used, and this was created by Cherokee actually and shared with us. And so I work with the Cherokee psychologist, and we kind of use this same format to help with transition. So it looks over medical issues, eating, sleeping, sensory stuff, all sorts of the domains of development, motor, language, self-care, what kind of interventions they've already had, family history, behavioral issues, and social functioning, play interests. So it's a pretty nice way to gather a lot of information in a brief amount of time, so you're not just going in cold. Let me go back to the PowerPoint here. So I think the clinical interview is one piece, and then the STAT is another piece that we've incorporated in. It's the screening tool for autism in toddlers and young children, and it's designed for kids in the 2 to 3 year old age range. It has 12 different interactive items that take about 20 minutes to administer. And if you're familiar with the ADOS, which is more of like this gold standard assessment for autism, it's like a mini ADOS. And it helps differentiate kids with autism, even from those who have other developmental delays that are not autism, which is nice. And so they have all these different administration items like the ADOS, and the 4 domains that they're looking at are play, requesting, directing attention, and imitation, like these core things that would be really central social emotional things that you're going to assess for. And you can go, I went to like a 2-day training through Vanderbilt and got certified in this, and when I did it, you could go for free and they would send you this whole stat kit, which is like $500 for free, because they're trying to kind of get it more widely disseminated. And then each administration cost $1, which is not too bad. So let me show you what we've done is, so we'll go in and do this assessment, which takes about 15 or 20 minutes. And then in our EHR, we have created, I just created like a little 1-page assessment write-up template where it's kind of like just plugging in what scores they got in each domain and just quickly just typing a few notes to individualize it to that kid, but having a lot of this stuff already done for you. And so it kind of goes through each domain and each of the 12 items. So an item might be an example of the play domain, turn taking, whether or not they can roll a car or a ball back and forth for 3 consecutive turns, or whether they have some kind of imaginative play with a doll or stuffed animal that's provided, whether or not they can request things like bubbles with eye contact and some kind of verbalization. So it's a pretty interactive way to assess some of these things rather than just relying on parent report, and it really is feasible to do in a brief primary care visit. Any questions about the STAT so far before I move on? And I'm happy to share these if folks want to look at them for themselves later and email them. A few other things I think that we could consider that might be feasible depending on funding. We used a little bit of grant money to buy the autism spectrum rating scales, and you can send a parent a link in their email and they can complete it at home, and then it automatically scores it and sends you a report that has some T-scores on it. That's been a nice addition to add to a clinical interview and the stat. I find though that if parents kind of are already biased towards autism, it seems like they're pretty transparent questions, and it kind of comes out in the way that parents think it's going to come out, it seems like. Another one that we're about to implement in our clinic on a universal level is the ages and stages. And it's nice because it actually has parents go through and answer specific developmental milestone questions around these domains of communication, gross motor, fine motor, problem solving, and personal social. And so it provides more of like a visual output here as well that you can use. And there's been some research to try to see that show that especially this communication area can help predict kids who are on the autism spectrum if it's significantly low. So my point today is not to kind of give you an in-depth understanding of any of these, but just kind of hey, this is out there in case you would want to incorporate part of it into your protocol. And then this is all kind of putting it together. Here's the protocol that I usually use. The warm handoff, and during the warm handoff visit, I spend about 5 to 15 minutes doing the MChat follow-up interview and observing the kid. If they failed less than 2, then we'll reassess at the next well-child check. If they failed more than 2 or we have some kind of concern, then I'll give them that developmental history form that I showed you and email them the autism spectrum rating scales or a BASC, and then schedule a follow-up visit. And then at the first BHC follow-up visit, which is about 25 or 30 minutes, we'll review those forms and those assessments, and I will conduct a DSM-5 clinical interview. But the time it takes to do that is drastically reduced because we already have all this information going in. So we can ask some clarifying questions, get a few examples. At that point, if I don't think it's autism, then I'll work with the PCP to place any referrals that are needed or follow up on any like developmental delays that might be present, and potentially kind of shift gears and more toward an intervention focused visit to work on behavior problems or social skills deficits. But after that, if there's still concern for autism, then I'll bring them back for a second visit and administer the stat. And at that point, you have a pretty good idea whether or not they have autism. You know, if it's too complex at this point or at any point, then we refer to the developmental psychologist for the whole workup, and just let them know it's going to be a little bit of a wait list, a wait time. But what we're trying to use is the stat to be able to say, okay, kids who clearly don't have autism, we can rule you out without having to stop up the whole referral network to the developmental psychologist with all of these folks that are easily ruled out, and clearly rule in and diagnose the kids who obviously do have autism, that the Walmart greeter knows has autism, right? They don't need to necessarily go through all of these comprehensive assessments to show that. So in this final session, we'll bring them back for a feedback session to review the results of all of this, to make a diagnosis or not, and then to give education, resources, different recommendations, and try to get them placed up with any referrals that they might need as well. And this is just kind of a general protocol, but we don't always follow it exactly each time. It really just depends on the family, but these are kind of the active ingredients that we've tried to put together. If it's a slow clinic and the family has time, maybe right after the follow-up interview, I might do the stat right then if it works out. So I think especially these 2 sessions, like session 2 and 3, could be switched even, like if you wanted to do the stat even before you did any of these other developmental interviews or anything like that, you could. So I wanted to just throw that out there and see what you all thought, see if you felt like this is controversial, if you felt like it would work for your setting or not. I'm just interested to hear some feedback from you all.
This is Allie. Personally, knowing that you were going to be doing this presentation, this is something that I've talked about with our clinic manager here, because we have a similar situation, Matthew, where we have a really good group that does evaluations for autism, but basically it's going to be 6 months to a year before you actually go through that. And some of these kids are slam dunks from the beginning. And so we were kind of questioning, how do we know and how do we create a process that works, especially for those kids that maybe don't need to go through that entire evaluative process. And so this is something I was really excited for your presentation to bring back to, you know, our clinic too, and say, look, this is something that's being done somewhere else and at least a possibility for us. Because I do follow up on MChats, but this other piece, it feels like we're really missing. So I really appreciate it.
And really, when I went to the stat training, they were billing it as pediatricians should be doing the stat, and then kind of just using the stat and their observations to make the diagnosis then. And I don't know, the psychologist in me was like wanting to add a couple more assessments to kind of, confirm multiple different sources and not just rely on any one thing. But the study that they did on the stat did find that there were very, very similar identification rates compared to the full ADOS in the kids who they were identifying with autism or not, even though it was drastically shorter time frame and a lot less training to administer. But of course, like you need to know child development. You need to know some of these things that, why the questions are the way they are. So I think it does take some folks that have some background training already in some of this stuff to make it work. But
yeah, I'm glad you said that, because that was one of the things that I've been concerned about with doing autism evals here in the clinic, because there is that delay with getting them in for more comprehensive evaluations. Is there a briefer way to do an assessment that's still reliable and valid when we know there's this gold standard of the ADOS? And so if there's any like predictive validity of, or, sensitivity, specificity, do kids actually have the diagnosis when we take this approach? Yeah, it would be good to know.
Yes, and you can Google the stat on the Vanderbilt website, and it has all of the research studies supporting it on there. What they did was they evaluated kids with the stat and also gave them the ADOS. And that's how they structured one of the studies to see how similarly or different each one by itself categorized the kids.
Nice.
And Matthew, as you were talking, it almost sounded like I haven't seen the stat yet, and I do the ADOS a lot, and the ADOS too, I guess I should say now, but it seemed like it was like a mini ADOS from your
description.
It really
is, yeah.
Yeah. So I think if for folks who are familiar with that, it would be an easy transition too. And what great to have it available in more primary care than having that more larger referral to a full battery.
I think the other part that has been, I guess, an issue with our clinic is like the cost part, which, has kind of precluded me from doing assessments from getting an ADOS here. And I know you said the same thing with the stat, that it's like $500. And so I don't know, if the same thing's going where if you do one of the trainings, you can get it for cheaper. If there's another option, like I know with the ADOS, they're very much about you need to get the kit. Like you can't get toys that are like the toys because there's specific things that the toys are pulling for. And so, yeah, I don't know what your thoughts are on that or the cost of part of things.
Right. When I did it, it was I believe it was a free training, and then they gave us the materials as well. And so I don't know if that still stands, but they sounded like they were open to trying to get it disseminated into as many places as they could. And then the stat protocol itself is only $1 per administration, which is not too bad.
Really cost effective, yeah.
Yeah. And so this is, I don't know if you all can still see it, but this is the Vanderbilt website that that talks about it. And so you would go to a training, and then what they do is they send you a CD of some administrations, and then you code it and send it back, and that's kind of an additional way you get standardized in it. You can also though do a training online, like you don't have to do an in-person training. And so I think the online training is like $200 or something. But for us, we have like in the department, we have like some educational monies each year for conferences and everything. And so I was able to use some of that. And but I know it is harder for other places that are more strapped maybe for resources like this. But I mean, if as the clinic, if you pay for any other screeners that you administer, I mean, you could kind of sell it as, hey, this is just another way that we're providing services, and really, you know, it's a way of the clinic to, I think, advertise what they're doing and kind of get a good reputation within the community as a place who provides this kind of comprehensive care.
Matt, this is Tanya. Thank you for presenting on such a great topic. I'm curious, the stat is just kind of a very restricted kind of age, like 2 to 3 year olds. What do you do for kids older than that? Because I know we get a good majority of kids that are being screened, either the 18 to 24-month-olds, and a lot of kids around that age 4.
Yes. So when I went to the training, they were saying that all the research has been done on 24 to 36 months, but they were advocating for it to be used down even potentially to 18 months, or, you know, kind of having a little wiggle room on either side of the 24 to 36 month age range. But if it's a kid who is 4 or 5 or older, I don't use it anymore, and we just refer them on to for more of the comprehensive evaluation. So it definitely is not solving all of the problems, and I don't have I don't have kind of a whole protocol or feel like I have the expertise to, you know, to diagnose teenagers or other older children without some backup in terms of assessment resources. So it really is kind of this restricted age range, but it is also an age range that we're also identifying kids a lot in that range and referring them out. So I'm hoping that, you know, in the long run, this will at least help decrease the wait times on some of these, for like on some of these specialty evaluations.
Hey Matt, this is Cody. I really appreciate this because this is something we've been kicking around doing here at Nationwide. The chief of my department is also the chief of the Child Development Center who does our autism evals, so he's kind of got a foot in each camp, and we've been kind of hammering out some of these details. And one of the details is your first visit. It looks like the first BHC follow-up, that 30-minute visit where you do the ASRS and the BASC. We try to stay pretty integrated here, so like 80% or more of our appointments are on the PCP schedule, so we try to maintain that as much as possible. And so this is a place that we've been talking about like what is the incremental validity of doing like the ASRS or a BASC or that full interview, that full 30-minute appointment. And I know you might not have data on it, but just from your own personal experience, do you feel like you're getting a lot from that? I know you hinted at the ASRS kind of telling you whatever the parents were already saying. Do you feel like that's an essential part of your process?
So yeah, we are just trying to start off. We've only been doing this probably for 6 months or more, and so I'm still trying to tweak it, and I don't have any research data on how much some of these things are adding to the validity. And so I feel like the BASC almost has been nicer than ASRS because it gives you a little bit broader overview of any of other concerns that the family might have, and because it has all those different domains that it's looking at. For the ages and stages, we haven't started that yet, and that's more of a universal screener. So I was thinking about substituting the ASRS or BASC with the ages and stages that they're already going to get coming in. But, you know, I think it's more of an empirical question that I don't know yet. And I'd love to partner with anybody on a research project that's thinking about rolling this out in a broader sense to try to look at some of that data. I know that Cherokee Health Systems is rolling this out throughout their whole system with their BHCs. And so folks are doing it. It's just a matter of getting some of the data to support it.
Hi, this is Naftali. I just wanted to say, make a couple of comments. One is this is a great presentation. Thank you so much for it. The other thing is, to that last comment, is that I think, and I'd be wondering what you thought about this. I think one of the things that I've found in my career in building programs is that that question of what the incremental sort of value of adding another instrument or another piece to your protocol versus just sort of gathering information as a clinician often goes to sort of the size and scope of your program and the people involved. And the larger your people are, if you have a lot of BHCs, the more structured sometimes you have to be, because their individual clinical skills and their assessment and maybe their developmental knowledge, developmental psych knowledge is sort of variable. You tend to have to structure things a little bit more and can be less loosey-goosey. And the less clinicians you have to manage, and you can sort of trust the clinical skills of the individual involved. So it's just an interesting piece to add to the thought behind how do we pare these assessments down to something that's minimally manageable but maximally helpful. So just some thoughts, and you can respond to that if you wish.
I think that's a great point, and I'm the only BHC that works in our practice. It's just one site, and so this has really been just a pilot. Can we make a brief assessment protocol that, one, is helps diagnose kids reliably, and but also is not so cumbersome that it can't be feasible in that setting. So I'm looking to try to gather some data on this over the next couple years, and try to reach out to other folks who are interested in doing this, and trying to get some data on it.
Well, in the interest of time, Matt, thank you for such a wonderful talk. Does anybody have any